Good afternoon, everyone. My name is Mike Donald. I'm an A&E consultant based here at Ninewells. I am the clinical lead for the East of Scotland Major Trauma Service. My background is that I trained in Ninewells with some time overseas, working on various rescue aircraft, managing major trauma before completing my SPR training in emergency medicine. Subsequently undertook secondments with London's Air Ambulance and various other air ambulance charity and providers in the southeast of England before joining the Emergency Medical Retrieval Service on the west of Scotland, where I worked for 10 years concurrently alongside my job as an A&E consultant here in Ninewells. I took on the clinical leadership of the East of Scotland Major Trauma Service approximately 4 years ago, took over from one of my colleagues, Mike Johnson. And really this short presentation this afternoon is to give you a sort of general overview of what the East of Scotland Major Trauma Service looks like, where it fits into the wider national network, and give you a bit of a sense of where we have come from, where we are hoping to go, and to introduce you to some of the key team members who are employed by the service and provide both care from the front door all the way through to discharge from rehabilitation. Tom, unfortunately, or Professor Farden, unfortunately, is off sick and isn't here to chair the meeting. This meeting will be recorded. I expect I'll talk for somewhere between 25 to 30 minutes, which should leave a bit of time for questions at the end. So, major trauma. What is major trauma? Well, trauma is derived from the Greek word for wound, essentially. Major trauma is a technical description that is given to a specific injury severity score, which is pretty meaningless both to clinicians at the point of receiving these patients, as it is a score that is calculated retrospectively, usually within sort of 48 to 72 hours of having fully delineated the injuries. So I prefer this NICE definition, which is that of an injury or combination of injuries that are life-threatening and could be life-changing because it may result in a long-term disability. And one of the key themes that I hope to share with you over the next 20 to 25 minutes is that this isn't a presentation about life-saving per se. This is about giving life back, which is one of the key strap lines of the Scottish Trauma Network. And it is by no coincidence that the bulk of the funding that was made available through Scottish Government to the Scottish Trauma Network during its inception was geared towards the rehabilitation phase, which for me as a front door and pre-hospital care provider has been incredibly enlightening. And quite inspiring also to see how the range of inputs from the multidisciplinary team impact on the long-term care for these patients after they leave our A&E and intensive care units and the major trauma ward. Our vision and strategic aim is to provide high quality evidence-based care. Now, providing evidence-based care within the realms of major trauma is quite challenging, as there are not a huge number of high value randomized controlled trials for us to draw really strong evidence. And most of the clinical pathways that are developed are on the basis of expert opinion, Delphi consensus and best practice, and historical evidence that has been gathered over many years. And I quite unashamedly would say that we have pulled a lot of the work around major trauma care in Scotland from the experience that our colleagues in NHS England had, who went live with their major trauma service back in 2007, 2008. Like most things north of the border, it's quite useful to have watched what they did and then made it better. And I do believe that a lot of the systems that we have in place, particularly around the pre-hospital and retrieval phase of the patient's journey, is optimal compared to those of NHS England. The second arm really of our strategic aims is to deliver the saving lives and the giving life back. As I've already mentioned, the giving life back is absolutely fundamental and a key element to this, but also supporting Scottish Government and NHS Tayside's Right Care, Right Place, which plays into the networking of trauma care delivery in Scotland with the evolution of major trauma centres, trauma units and local emergency hospitals. So this is a graphic to represent how the Scottish Trauma Network is configured. There are 4 major trauma centres based at Aberdeen Royal, ourselves here at Ninewells, Edinburgh Royal Infirmary, and the Queen Elizabeth University Hospital in Glasgow. Now, I'm not sure whether you can see it on your screens. I think the most interesting numbers to note on this is the percentage of trauma that is seen in each of these major trauma centres. So you can see on the west of Scotland, they take the lion's share. They take almost 50% of those patients that have sustained major trauma, with the southeast in second place with just under 30%. Aberdeen Royal see around 15%, and we in the east of Scotland see around about the 8% mark. So we are by definition the low volume centre, and for many, many years we have had to make the argument around how volume influences outcome, in that there has been this pervading sense that is not backed up or justified within the medical literature that you have to have high volume in order to provide optimal outcome. And the evidence that is available is very supportive of low volume major trauma centres, and a number of our European counterparts, Germany in particular, have opted for having multiple small or low volume major trauma centres that are geographically placed in higher areas of population, and their figures are very comparable in terms of mortality to ours. This was a very challenging argument that my predecessor, Mike Johnson, had to make, and there was a lot of quite complex geospatial modelling that was undertaken to looking specifically at what the optimal model would be for Scotland, whether it was a 4, 3, 2, or indeed a one centre model, and actually whether all the money should be channeled into 24/7 all-weather capable transport platforms that would bring the patients into a single centre located somewhere in the centre of Scotland. But for a number of reasons, mainly political, the options appraisal that came out was for us to go with a 4-centre model. Now, this is and will remain under review, and we have always said here in the East that if it was found that we were underperforming, or indeed that our patients were not receiving care that was optimal in terms of their both their survival statistics, but also their long-term disability, then of course that this model should be re-examined. It's very pleasing to see that on the back of all of these arguments in terms of volume and outcome, that if we plot a funnel chart in regards to something called the W statistic, which is a statistical calculation based on a given combination of injuries, whether the patient has sustained blunt or penetrating trauma, and how old the patient is, you are able to retrospectively compare that patient's outcome against a huge cohort of historical patients that have sustained similar injuries, and come up with a statistic that allows comparison between both the trauma units and the major trauma centres. And where we sit right in the middle, just above that second green dotted line, is, without being statistically significant, indicative that the care that we are providing locally delivers better or statistically better outcomes for our patient cohort compared to the other MTCs in Scotland. Now, for many years we sat above the 3 standard deviations. And what we are seeing as the other systems within the other networks mature, because there was a graded start to the MTCs, with Aberdeen going live, us going live a month later, and then there being a 2 or 3 year hiatus before the QE and Edinburgh Royal came on board. Is that I think what we'll see over time is, and what is best for patients, obviously, is some parity between the centres in terms of outcomes, and that this line will flatten out even more. But it certainly is, I think, justification for the existence of our major trauma centre, and also underlines the care that is provided to our patients on site here. Our region is a mixed urban and rural population, and for a lot of the reasons that I personally believe it is probably the best place in the UK, if not Europe, to live in terms of quality of life and access to outdoor activities with reasonable road networks and hosting major events. But what comes with that is a sort of reasonable distribution of mechanisms of injury, from both the sort of rural and agricultural setting to sports activities. We've got the busiest arterial road running up the middle of our patch, the A9, which sadly continues to deliver a lot of business our way, as does the Tay Road Bridge. So we see a huge mix of mainly blunt trauma presenting to our MTC here, which is in quite a stark difference to those stats that are presented by our colleagues on the west of Scotland, where around about 50% of their what we call code reds, which is their patients that are hemodynamically unstable, major trauma patients, are as a result of penetrating trauma. So they see quite a large volume and perform around about, on average, 2 resuscitative thoracotomies a month for penetrating trauma, whereas locally we see much less in terms of penetrating trauma. We may undertake maybe between 1 to half a thoracotomy a year statistically. How are patients selected to go to the major trauma centres? Given our challenging rurality across Scotland, the Scottish Ambulance Service have developed a trauma triage tool. There is one for adults as well as one for children. And basically, the ambulance service practitioners that attend these incidents will run through a number of triage questions based around the patient's physiology, patient's injuries, the mechanism of injury, and then some special circumstances such as age, anticoagulation use, pregnancy, morbid obesity. And on the basis of these steps, they'll need to make a series of decisions where they are encouraged to exercise their clinical judgment as to whether they can get this patient to a major trauma centre within 45 minutes or not. And if they are not going to achieve that, for whatever reason, then they have some topside support from a critical care or trauma desk, which is located with ambulance control room in Glasgow. And I think what's interesting from a sort of, if you're not involved in this area of practice, is to understand that in Scotland, on a daily basis, the ambulance control rooms receive approximately 4,500 999 calls a day, of which around about 10 will be representative of patients that have sustained major trauma and have got critical care needs that outstrip the clinical capabilities of a jobbing ambulance service technician or paramedic, and therefore require some enhanced care. So there are clinicians screening these 999 calls, sending appropriate resource, whether that is physician-based response teams or advanced paramedics, to the scenes of these incidents to then stabilize patients, to then allow them to perhaps go out with that 45-minute transfer zone if perhaps they've been intubated and ventilated or received blood product transfusion in order to improve their physiology. So that's how the decision making is made pre-hospital. What has changed in terms of us adopting a major trauma service is that traditionally those patients would have been pre-alerted to the emergency medicine service, and the emergency medicine service would have managed the initial resuscitation and management phase with an invitation extended to our inpatient specialty colleagues to attend on the basis of what we as an emergency medicine service perceive their most pressing needs to be. And what that ultimately resulted in is a number of phone calls, which were being performed concomitantly as rapid sequence induction of anesthesia, the setting up of massive blood product transfusion, telephone conversations with the blood transfusion service about ongoing blood product requirements, and essentially distracted the de facto team leader from what was driving the patient and identifying what the immediate life-threatening concerns are and addressing that pathology as quickly as possible. So what happens now is that when we are stood up by the ambulance service or one of the advanced pre-hospital provider teams, we will disseminate a 222 call, of which we currently have 2 tiers, soon to be 3. The first tier, or that of a code red, where a patient is found to have been hemodynamically unstable and requires blood product transfusion, that would prompt a code red call, which mandates immediate consultant availability from both anesthesia, general surgery, and orthopedics, with an interventional radiology consultant also stood up and prepared and ready to intervene as required. Our standard or tier 2 calls for an adult or pediatric major trauma again would prompt the attendance of a multidisciplinary team, which would consist of a trauma advanced nurse practitioner who fulfills the role of scribe, and as well as specialties such as anesthesia, general surgery, and orthopedics attending and fulfilling the roles of the A, the B, and the D, the A, the B, and the C doctor, with the emergency medicine consultant team leading. One of the unintended consequences of putting this system in place was the disruption to business as usual, because of course all of these clinicians are undertaking busy clinical roles within Nine Wells, and we've become much more attuned and refined in terms of when we can stand these specialists down if when the patient arrives they're not as given, and on the flip side of that we can scale up as required if the patient is actually more unwell than was perhaps given. The acute or inpatient phase. So from the emergency department, there are 4 sort of broad dispositions that our patients will go. The vast majority, unless they are truly needing immediate operative intervention and go directly to theatre, the vast majority will go to CT for further evaluation of their injuries. From CT, they will either go to the interventional radiology suite to have their bleeding issues sorted, or to theatre, or to neurosurgical theatre, and then ultimately critical care, intensive care. They may go directly to intensive care, or they may go to the major trauma ward. Now, the major trauma ward is a new or de novo ward that was created within the orthopedic footprint at the opening of the major trauma service. It was set up as a 6-bedded unit with the ability to flex to 8 beds. It's what's termed a level 1.5, so it provides an enhanced level of care, and under the guidance of the trauma advanced nurse practitioners working very closely with the orthopedic consultant group, they will manage patients who fit these inclusion criteria, which are injuries to more than one body region, or a significant injury to a single body region, such as a high energy pelvic fracture, chest wall injuries, high energy open long bone injuries, 2-limb fracture or dislocation, or penetrating trauma with potential for deterioration. What we have found over the last few years is that we are finding major trauma patients, or patients who have sustained major trauma that perhaps haven't been fully understood to have sustained significant injuries, in all sorts of different corners of the hospital. And that was, I think, very well reflected and described by Fiona Watson a few grand rounds ago when she presented her chest wall trauma audit. And I think she had found patients who had sustained multiple rib fractures in, I think, between 7 and 8 different clinical areas within the hospital, which didn't come as a huge surprise to me, as a lot of these patients have multiple other issues that are best dealt with by other inpatient specialties. But what we would like to evolve, and what we have been evolving, is some outreach as well as inreach to these specialty areas from our trauma A&P services, who will come and make an assessment of the patient and can wrap around some of that enhanced rehabilitative care, in-service care, as required. So there are some contact details on this slide that I would refer you to, and the team are very open and are willing to accept these referrals and would welcome them to come and review these patients. The educational aspects, we have a lead trauma A&P who has conducted a number of simulation training sessions. So with to meet the ongoing training needs for some trainee A&Ps that are coming through, as well as the ward staff. And this is a slowly evolving area of the service that, now that we have gone through that implementation phase and are now part of the service delivery phase, will become much more prominent and to the fore. The major trauma ward also acts as the hub for our major trauma coordinators and the rest of the multi-trauma, multidisciplinary team, who I will introduce you to shortly, in order to wrap this rehabilitative care around the patient as close to the point of their admission and point of injury as possible. A special mention to our orthopedic colleagues. This is Mr. McInnes and Mr. Littlechild, who have started this just this year and have implemented our rib fixation service. This is a photo they took of our first patient who went through the rib fixation service. Traditionally, these patients would have been transferred up to either Aberdeen Royal or less commonly to Edinburgh Royal Infirmary to have their chest walls stabilized. There is good evidence that if you select your patients optimally, rib fixture fixation reduces length of stay, reduces morbidity, reduces the need for intubation and ventilation, and reduces length of stay within critical care as well. So we're really, really pleased that we've been able to get this service up and running and offered to our cohort of patients within the East region. The rehab team, I think, deserve a full separate slot at Grand Rounds, and I hope that we can set that up sometime, perhaps in early next year, because their work, to my mind, as somebody who was relatively uninitiated to this world of care, has been quite simply mind-blowing. And the feedback that comes through our service that I'm cited upon, a lot of our patients don't remember much about their acute or admission phase, but the feedback about the care, the personal care that was offered to their individual needs from both our occupational therapists, our speech and language therapists, our nutrition and dietetic colleagues, our clinical psychologists, and our vocational rehab specialists is second to none. And in my mind, this is where I think we have really seen our bang for our buck. And this is where we are able to demonstrate to Scottish Government that they are getting a good return on their investment. Some of the figures are very striking around the health economics of rehabilitation from major trauma. It's estimated that within the UK alone, the burden from neurotrauma or traumatic brain injury is somewhere in the region of £15 billion. And if you take that to an individual patient level, if we take one of our major trauma patients from the point that they end up needing lifelong support and care, to a point where they're able to re-engage with the workforce and are independent in their activities of daily living, there is a cost saving over that patient's lifetime of somewhere between £4 and £4.5 million. So the Scottish Trauma Network, when it was set up, based on the figures from NHS England, hoped that we would save approximately 40 more lives than were being saved on an annual basis than were being saved prior to its inception. And that was certainly demonstrated within NHS England. What I don't think that they have fully evaluated is how much of that life has been given back and how important that has been to the patient group. And I think that we've got a really good opportunity in Scotland to try and put some figures around the health economics around that. The ward has quite extraordinary rehab facilities. Now that picture up in the top left-hand corner of your screen may not look like much, but those of us that share offices with 5 other consultants and are fighting over a single PC know how precious real estate is within NHS Tayside. And to have this secure private space for our clinical psychologists who are experts in delivering care after major trauma are able to take patients into this area and perform their evaluations and provide that support is so important, and it really is like gold dust. As well as the sort of co-located gym facilities, which means that patients aren't being sort of moved from pillar to post as they undertake their rehabilitation journey. This schematic, which I won't linger on for long, but I think gives a really good overview of all of the stakeholders that are involved in major trauma care in the east of Scotland. The list is considerable, and in my mind, major trauma care is really the optimal team sport in terms of passing the patients on from one phase of their journey to the next as seamlessly as possible. And I've seen that replicated, and what I hope to demonstrate in some of the patient stories that I'll move on to very shortly is just how much care each of these specialties take in delivering that optimal care and don't want to be seen as to be the ones that are dropping the ball. If you continue that sort of sporting analogy, from that point of injury all the way through to discharge. The backbone of the governance and the creation of our audit is through the Scottish Trauma Audit Group, which is is one of a number of the national audits within the SNAP programme. We have 3 local audit coordinators here in Ninewells whose job it is to troll through every trauma case that comes through the doors of both Perth Royal Infirmary and in Ninewells Hospital, and will evaluate their injury load. They will score them. They'll provide an injury severity score, and from that, a probability of survival. But alongside that, they will gather information about whether we're meeting key performance indicators that are nationally agreed across Scotland and are into 3 sort of wider categories. So the pre-hospital phase, an example of a KPI from there was, what did the patient receive tranexamic acid within 3 hours of point of injury? The early hospital care, an example of one of the KPIs there was, was the patient received by a trauma team leader who was as a designation of a consultant. And then within the ongoing hospital care, we undertake patient-reported outcome measures, which have to be performed at various times. And we also have some rehab KPIs that need to be adhered to also. So these are reported and are compiled into an annual report, which is freely available online through the STAG website. In terms of numbers and volumes of cases. So in the top table, this are our adult cases from 2018 through to 2022 with our pediatric cases below. Without going too deep into the figures, what we have seen since we went live in 2018 is a year-on-year increase across the board in both our minor, moderate and majors, with a 42% increase in total number of patients included in the STAG audit. So there is definitely some truth in that if you build it, they will come. And that has been replicated, and we expect to see further increases as we go on through this as well. Just a quick photo. These are some of the core members of the team. I will bring, and she'll be very embarrassed, but some special attention to Fiona Hutchison, who is in the middle of this picture with the glasses, sort of half in the sunlight. This is typical of Fi. She never really wants to be seen in the sunlight, but she is the absolute backbone of this service, and almost single-handedly has kept us on track through a peer review process, which was undertaken earlier this year, where we had stakeholders from NHS England as well as from representation from the other regions who came and picked through our service with a really fine tooth comb, and it was a very robust process that was undertaken, and thanks to Fiona and the wider team, we were able to defend our position and receive very, very positive feedback from that peer review process. So if you have any questions, please either come to myself or come to optimally Fiona, because she really does know the answers and knows this service better than anybody. So look, that's just about the half an hour mark. I'll spend the next 10, 15 minutes or so just, we've picked a few cases just to sort of highlight the pathways, and then I will stop, and hopefully we'll have a wee bit of time for questions. So the first case is technically a pediatric major trauma case. So this was a 14-year-old chap who was out mountain biking here at Forfar Quarry, and was discovered and found unresponsive by his friends who he'd been out mountain biking with. When the ambulance service eventually found him and arrived on scene, he was found to be unconscious with a GCS of 3 and a fixed dilated right pupil. Because of the nature of his injuries, the Tayside trauma team, so one of my A&E colleagues and resuscitation nurses, attended to this chap outside of the hospital. They provided a rapid sequence induction of anesthesia. He was intubated, he was ventilated, and a pediatric major trauma team was stood up to receive this patient at Ninewells, where he was rapidly transferred to CT, where he was found to have a traumatic brain injury. You can read the findings from the CT report. He was found to have, a combination of injuries within his brain, including some diffuse axonal injury, which, for those of you that are familiar with TBI, is and can be quite a poorly prognostic feature on early CT scans. He also had a facial fracture, and his injury severity score was calculated at 30, with a probability of survival of just under 79%. So this young lad spent 20 days on our adult intensive care. He was a big lad. I think if this was to have happened within the last year, there is a higher likelihood, I think, that he may well have been retrieved to a pediatric intensive care unit at Sick Kids in Edinburgh. However, it's an absolute tribute to our colleagues within our adult intensive care unit, who for many, many years have provided very safe and effective critical care to a pediatric population. And they were very comfortable that they were able to deliver optimal critical care to this chap that would have been commensurate to that of a pediatric intensive care. He had a trachea. He was stepped down to pediatric high dependency, where our pediatric colleagues took over his care. He had a gastrostomy and some Botox injections for limb spasticity. He had a really extensive input from the multidisciplinary rehab team. Some joint care with the adult neuro physiotherapy team whilst an inpatient. At the time of his inpatient stay, we received a gravity reducing hoist, which allowed him to relearn how to walk. And he spent almost 12 months as an inpatient here, did extraordinarily well, and returned to school within that 12 months of him having attended here. There was quite a lot of media attention around him. Lovely, bright guy with a beautiful smile. Um, and the rehab team did an extraordinary job in terms of getting this chap back up on his feet and able to undertake his activities of daily living. Just to give you a bit of a sense as to what that time and input looks like. So he had in total 177 therapy sessions once he had been once he was discharged home. So a huge outreach into the community. Where is he now? So this was an update from about 3 or 4 months ago. So he still has some ongoing neurological difficulties. There has been a referral to Glasgow for a deep brain stimulation due to an ongoing tremor in his left hand. But he's back in the gym. He swims. He's able to walk the circumference of Forfar Loch. He's been discharged from physio. He's been paddleboarding, skiing, he's done some supported canoeing, and he's planning on going to college. In fact, he may well be at college as we present his case down here. And he was, I think, so inspired by our physiotherapy colleagues and our rehabilitation colleagues that he plans to pursue a career in physiotherapy, and he's leading a life as an independent young man. And there he is there, an extraordinary recovery. The second case is a 29-year-old male. This was a chap who lost control of his motorcycle, was thrown, probably struck a bit of street furniture, probably a lamppost, and ended up embedded under the front wheel of a stationary car. Initially conscious and engaging with the first responders, rapidly deteriorated en route to hospital. Um, was peri-arrest as he was transferred in, had a full cardiac arrest, underwent a clamshell thoracotomy in A&E, required some internal cardiac massage and compression of his descending aorta, had a return of spontaneous circulation, and was found to have avulsed his left subclavian artery, as well as having sustained many other injuries across different body regions. Ultimately, ended up having to have his left arm amputated and had an incredibly stormy critical care recovery period. That's a summation of his injuries. So this poor chap had completely avulsed his left subclavian artery. It was not amenable to surgical repair and required embolization by our interventional radiology colleagues, with the acceptance that would require him to have a high amputation of his left upper limb. He had multiple thoracic injuries. He had a brain injury, a left open femoral fracture that required nailing. He had multiple other small bone fractures, and his injury severity score was listed as being 50 with a probability of survival of 25.5%. So he is a true unexpected survivor. Once he had got through his rather stormy critical care phase, made a very strong and good recovery with a huge amount of input from both the inpatient and community rehab team. A huge amount of input from the nutrition and dietetics to manage his sort of critical care sarcopenia. A lot of work in terms of how to relearn using unfortunately, he was left-hand dominant. It was his left arm that he lost. And he was referred to lots of our third sector partners to help with his ongoing care also. He recently returned to the major trauma ward with some of his pals. He's quite an interesting character, very strong individual in terms of the way that he's psychologically recovered from this. Very strong support network with friends who raised quite a considerable amount of money for the physiotherapy team here within NHS Tayside by climbing the 3 peaks. I was a wee bit I was a wee bit concerned when I heard that that's what his friends were doing, as we'd had another incident where a team who had been attempting the 3P challenge, which is, you know, the highest peaks in Wales, England, and Scotland, within 24 hours had actually crashed their vehicle, probably due to driver fatigue. However, they I think had thought that one through and had a reasonable driver to undertake that, and did well. And then finally, another chap, 59-year-old male, who unfortunately brought his arm in a miter saw at a local primary school, and sustained a near complete amputation of his forearm. A makeshift tourniquet was applied on scene, followed up by a combat application tourniquet, and he went directly from Research, having been received by the adult major trauma team, with vascular surgical input and consultant plastic surgical input, and was admitted to surgical HDU following his operative repair. He had his operative intervention. He had to return to theatre on a number of occasions to close the wound, etc. And then he embarked on what was an extensive period of rehabilitation with our colleagues from both physiotherapy and the hand therapy, and the vocational rehab service also. Interestingly, this chap was a professional sessional museum. He was very well known and well regarded in the musical community, and there was definitely a sense from him that he had lost a lot of his the way that he perceived himself. And Moira Moulton, who is our clinical psychology major trauma lead and also our rehabilitation lead for the East of Scotland, and spent a considerable amount of time with him working through these various issues, to the point that, you know, he has now gone back to trying to relearn to play the guitar with his other hand. He's back working and has continued and has. And it's very interesting talking to Moira and her clinical psychology colleagues, because this again is a persistent theme that we hear from our patients who go through our pathway, in that a lot of them do have this renewed vigor and joy for life, which Moira has got a technical term for it, which I think is post-traumatic growth. I think that's right, Moira. I can see you on the screen. Can you nod? Did I get that right? Oh, a thumbs up. That's good. So this period of post-traumatic growth after what has been a life-changing or life-threatening event, and also this sense that they want to go back and support others. There was a huge sort of outpouring of emotion within the musical community. He had played with Deacon Blue and the Bluebells. They put on a gig at the Caird Hall, and he was invited up onto stage and made a special mention for, you know, one of our hand rehab specialists and our physio team, and extended his grateful thanks to the service for getting him to the point where he felt comfortable and confident enough to get back up onto the stage. And this was the quote that he sent in. He felt that actually his life had been enhanced. He'd been struggling a bit before this with a host of different issues, and this really provided an opportunity to recalibrate and kick on. So that's the end of my presentation. Thank you very much for all of you who've stuck with me through that. I will stop sharing my screen. I'm very happy to take some questions for 10 minutes or so. I also have quite a number of the team on the call also that I'll be able to direct any sort of tricky, particularly rehab questions towards. So thank you all very much indeed for the opportunity to present today. It's been my pleasure. Thank you.